So good morning everyone. Okay, it is just a continuation class of the secondary glaucoma topic which I was taking on Monday. Okay, due to some technical issues we stopped actually. So this will be a short class. I'll just cover up whatever is not covered in the last class. Okay, till just for a recap, if you want to know like what is it, if anybody asks if secondary glaucoma comes as a short note, you just have to know. So raised IOP, the glaucoma caused by any ocular or systemic disease is secondary glaucoma. And again, it is divided into open angle glaucoma and angle closure glaucoma. And the important topics of secondary glaucoma I have covered already. That includes lens-induced glaucoma. So in lens-induced glaucoma also in detail I have covered. Okay. Then neovascular glaucoma, steroid-induced glaucoma. So all those important topics I have covered in Monday class. So today it is just for continuation and for completion's sake, okay? Rarely all this is asked for undergraduates. Now today what I'm taking, but for completion's sake, I'll finish off this, okay? So ciliary block glaucoma is also a type of secondary glaucoma. It's a rare condition which may occur as a complication of some surgery. So the surgery is mainly following trabeculectomy surgery, okay? It is characterized by marked raised IOP associated with shallow AC. So what happens here is the tips of the ciliary process rotate forward and block the forward flow of aqueous humor. So aqueous humor, you know, the drainage of aqueous humor. The aqueous humor is produced from the ciliary process and it is the main form which is seen in anterior chamber. But instead of flowing into the anterior chamber, which will divert posteriorly, this aqueous humor divert posteriorly and collects as aqueous pockets in the vitreous. So this leads to raised IOP. The iris lens diaphragm is pushed forward and IOP is raised and anterior chamber becomes flat here. So this is the picture where there is a raised IOP. There is no anterior chamber at all. The iris is so much pushed forward and then cataractous lens also you can see. See, this is the pictorial depiction where the iris, the rotation of the iris process is seen forward. Okay, so the iris is pushed forwards. AC is almost flat. There is no AC at all. So the aqueous humor, instead of draining anteriorly, it will drain posteriorly and forms the aqueous pockets in the vitreous. Okay, so this causes ciliary block glaucoma. The clinical features are like there will be persistent flat anterior chamber following an intraocular operation, and then markedly raised IOP will be there. And then when we do a serial test, that is serial test is negative. So this is a simple test what we do post-operatively to see whether the anterior chamber is intact. Okay, where fluorescein dye is in detail may not be required, but just interested candidates can listen to this. Okay, fluorescent dye is just placed where there is a wound and we see whether there is a dilution of this fluorescent dye. If there is a dilution of fluorescent dye, then that means there is a leakage from the anterior chamber. If the fluorescent dye is intact like that, then it is a negative Seidel test. That means the wound is properly closed. But still, if the wound is closed, the anterior chamber is shallow here. So the management is, first we have to try a medical therapy, okay, which consists of 1% atropine. So dilate the pupil here. This is the only glaucoma where atropine is used as a treatment, okay, whereas atropine is contraindicated in all types of glaucoma, okay. So never utter a word like atropine in the treatment of glaucoma in any other cases, except for in ciliary glaucoma, we use atropine drops as a treatment here, just to push the iris lens diaphragm back, that's all. Then acetazolamide orally 250 milligrams QID is given and 0.5% timolol eye drops, that is beta blocker, is used to reduce the aqueous production. Then intravenous, because the IOP is very high, the line of management will be giving intravenous mannitol to cause detergence of the vitreous gel, because all aqueous pockets can occur. Even with all this medical therapy, if it doesn't respond, then we do a YAG laser hyalidotomy. Hyalidotomy means we hit a laser YAG, that is YAG laser, to the vitreous phase, okay, to break open those aqueous pockets. Then surgical therapy is in the form of plans. So if it doesn't respond for all medical therapy, YAG laser, then final resort is surgery. That means what we do is we clear off all the vitreous by doing a pars plana vitrectomy. With or without lensectomy is the treatment of choice. So moving on to next type of secondary glaucoma, that is glaucoma which is caused due to uveitis. So again, this can be classified into hypertensive uveitis and post-inflammatory glaucoma. So in hypertensive uveitis refers to acute inflammation of the anterior uvea associated with raised IOP. Okay, uvea chapter, if they have finished, I think one of the complications is secondary glaucoma. It includes non-specific hypertensive uveitis and a specific type. So specific type means it is associated with some syndromes. I'll be talking about that now. Okay, the non-specific one, uveitis, is all cases of acute inflammation of anterior uveal tract which is associated with IOP. So how does this raised IOP occurs in uveitis is, it is a type of secondary open angle glaucoma which occurs because of clogging of the trabecular meshwork by inflammation. In uveitis, what happens? There will be a lot of inflammatory cells in anterior chamber. This inflammatory in aqueous humor. So these inflammatory cells exudates, they go and deposit and clog in the trabecular meshwork. Okay. So that is one mechanism. The other mechanism is there may be inflammation of the trabecular meshwork itself. Okay, there may be edema there. So that is called as trabeculitis. So this can occur, and then there will be prostaglandin induced rise in IOP. So these are the mechanisms how raised IOP occurs in uveitis. Then how do we treat? Always in secondary glaucoma, you treat the cause. So the cause is iridocyclitis. For iridocyclitis, I think everyone knows the treatment for iridocyclitis. That is, steroids have to be given to control the inflammation. Then additional to that, medical therapy to lower the IOP. Okay, this is a picture where there is a posterior synechiae. Can you see posterior synechiae here? Okay, this is a case of uveitis. There is a circumciliary congestion, posterior uveitis, and a little bit of corneal edema. Okay. The specific uveitis syndromes includes Fuchs and Fuchs uveitis syndrome, and then other one is POSNER-SCHLOSSMAN syndrome. That is also called as GLAUCOMATOCYCLITIC crisis. Fuchs uveitis, what will happen is, it is a type of chronic non-granulomatous type of low-grade anterior uveitis. Typically occurs unilaterally in the middle-aged one. Okay, the salient features are heterochromia of iris. There may be diffuse iris atrophy. The pathognomic feature is fine capes all around so all the features of uveitis will be there. Okay, except like very faint aqueous flare will be there. And then how it is different from other uveitis is there is absence of posterior synechiae. In uveitis, you will see posterior synechiae. But whereas in Fuchs heterochromic iris, there is no posterior synechiae. Instead, there may be rubeosis iris, and then sometimes early complicated cataract will be there. So that is the presenting feature. Okay. The picture, see, you can make out there is the color of the iris is different from here to here. So that is what it is called as heterochromia iris is seen. Okay, this is what I was talking about, fine capes, that is stellate capes all over the cornea. Not only in that Alts triangle, that is inferior part of the cornea. Not only there, it is present all over the cornea, back side of the cornea, that is on the endothelial side. This is again the clinical picture of a Fuchs heterochromia iris, where there is heterochromia is seen along with the cataract. Okay, see this lens is clear, whereas this lens is cataractous. So how do we treat them is by giving a topical steroid, and then there is if inflammation is there, and then no need of giving cycloplegic as there is no formation of posterior synechiae. That's what I told you. Okay, but if there is a cataract, then again you need to take care that inflammation will be there post-operatively more, but you need to treat the cataract. Treat the cataract in the sense you have to extract the lens and then place a posterior chamber intraocular lens. The other syndrome which is associated with secondary glaucoma is POSNER-SCHLOSSMAN syndrome. Okay, here there is a recurrent attack of acute rays of IOP. It is the IOP ranging between 40 to 50 millimeters of mercury without shallowing of the anterior chamber. Fine capes at the back of the cornea without posterior synechiae, similar to Fuchs one will be there. Then epithelial edema will be there, a dilated pupil, but there is no congestion. This is the pathognomic one. So this is the speciality of POSNER-SCHLOSSMAN syndrome. A young male patient where the eye is quiet, but the patient is complaining that patient is having pain because of raised IOP. If we miss that, all this finding, then patient may go for glaucomatous optic atrophy. Medical treatment to lower the IOP, and along with that short course of topical steroids can be administered. Post-inflammatory glaucoma is almost similar to the post-uveitis. Uveitis is also a type of inflammation. No? So the IOP is raised due to after effects of iridocyclitis. So many mechanisms have been put forward. Okay. Now, in detail, I think it is not required for you. You just have to remember that all these inflammatory cells can go and block the trabecular meshwork, or there may be inflammation of the trabecular meshwork itself, edema there, which leads to open angle glaucoma. Sometimes, okay, this happens in acute inflammatory stage. After effects of this inflammation, there will be the post-inflammatory because of the synechiae. If there is a posterior synechiae, annular synechiae may be there. This may cause angle closure. Initially, it will be an open angle glaucoma, but later it may go to secondary angle closure glaucoma. Okay, so just a clogging of the trabecular meshwork can lead to open angle. But if it forms a membrane and this inflammatory debris in the contracts, and this causes angle closure glaucoma. So you can identify this picture, no? So a lot of posterior synechiae, okay, all over it is almost 360 degree. That's why it is called a seclusive pupillae, okay, where there is a blockage of drainage of aqueous humor there here from back to front. So this is a type of angle closure glaucoma. See here there is no pupil at all. So it is almost this is the occlusive pupillae. That is organized membrane is seen. This is the occlusive pupillae which has led to secondary angle closure glaucoma. So how do we treat them? Acute iridocyclitis should be treated to prevent the formation of synechiae. Okay. So curative one is to lower the IOP. What we have to do is give beta blockers. You can, but you remember one thing: prostaglandin analog should not be used in any inflammatory glaucomas. Okay. The first choice in inflammatory glaucomas are beta blockers, and if the beta blockers are also contraindicated, other forms, carbonic anhydrase inhibitors, all that form of medical treatment can be given. Then comes the surgical or laser iridotomy may be useful if there is total pupillary block. As I showed you the other pictures, like where the pupil is not found at all. So you can create a hole in the periphery, that is called as laser iridotomy, may be useful. Okay. If nothing works out, then the final resort will be filtration surgery. So glaucoma associated with intraocular tumors. For just completion sake, I'm doing any intraocular tumors can give rise to raised IOP. Okay, so the malignant melanoma of iris, choroid, ciliary body, and retinoblastoma can lead to trabecular block due to clogging of the tumor cells. In the inflammatory glaucoma, what happens? The inflammatory cells goes and blocks there. Here, the tumor cells goes and blocks there. Now, blocks the trabecular meshwork. And sometimes even a direct invasion by the tumor seedlings can happen, and then new vessels on the angle can appear, and which will lead to neovascular glaucoma also. Angle closure due to forward displacement of the lens iris diaphragm by increasing the tumor mass. If the tumor is pushing from back, then there may be angle closure glaucoma also. So what we have to do is treat the primary cause. All secondary glaucomas, you have to write this one sentence and then go ahead and treat the glaucoma. Treat the primary cause. That is, if there is, for all intraocular tumors, if it is occupying most of the eyeball, then you need to do enucleation. So this is the seedling, the tumor seedling, what you will see, you are seeing in the vitreous cavity. See, it is almost filled up. So if it is filled up like that, enucleation is done. This is a enucleated eyeball, what you are seeing. Then comes the glaucoma in aphakia and pseudophakia patients. Association of glaucoma with aphakia and pseudophakia is in the post-operative period, maybe because of hyphema, that complication of surgery. That means there may be hyphema. Hyphema means blood in the anterior chamber, so which would have led for raised IOP. Then post-operatively, as you all know, there may be little amount of inflammation. If the inflammation is severe, then this also can give rise to raised IOP. Sometimes while doing a cataract surgery, when we aspirate the cortical matter, a part of the cortical matter may escape the aspiration, and we would have left little cortical matter in the anterior chamber. This again can raise the IOP. One more complication of cataract surgery is the rupture of posterior capsule. So whenever there is a rupture of posterior capsule, the vitreous can gush from the posterior chamber to the anterior chamber, and then again this leads to raised IOP. The secondary angle closure glaucoma due to pupillary block can also occur. So raised IOP with deep anterior chamber in early post-operative period may be because of hyphema, inflammation, retained cortical matter, or vitreous. That's what I explained all this. If there is a shallow anterior chamber and then there is a raised IOP, that may be because of pupillary block, which is formed because of the annular synechia or vitreous herniation. So again, this can be open angle type or angle closure type. So the undiagnosed pre-existing primary open angle glaucoma may be associated with aphakia and pseudophakia. And then, as you all know, post-cataract surgery, what we prescribe is anti-inflammatory drug. The most potent anti-inflammatory drug is steroids. So when we use a steroid, some people will be steroid responders. Those are called. So they develop, when we give a more amount of steroids, post-operatively there will be raised IOP. The other uncommon things are epithelial ingrowth. Okay, so forget about this. So we have reached almost to the end of the session, secondary glaucoma causes. So the final cause may be following trauma also, patient can develop glaucoma. So how it happens following trauma is, the mechanisms are different. Following trauma, there may be inflammation. Okay, if there is a blunt trauma, pigment dissipation can occur, and then inflammatory glaucoma due to iridocyclitis can occur. Or then because of the trauma, there may be intraocular hemorrhage, which will lead to raised IOP. Sometimes in trauma, there may be a lens capsule rupture or a dislocation of the lens, which again leads to lens-induced type of glaucoma. Then because of the blunt trauma, sometimes there may be cleavage in the ciliary processes. So there may be angle recession. It is called as angle recession glaucoma due to disruption of trabecular meshwork. So the glaucomas associated with intraocular hemorrhage include directly the red cell glaucoma. These fresh red blood cells following trauma can block the trabecular meshwork and then cause a red cell glaucoma. Sometimes in fresh hyphema, nothing happens. There may be like a hemolytic glaucoma. It is acute secondary open angle glaucoma due to obstruction of the trabecular meshwork, which is caused macrophages. That means whenever there is a foreign body, that is red cells in the anterior chamber is a foreign body. So this is engulfed by macrophages, and these macrophages go and block the trabecular meshwork. So this is called as hemolytic glaucoma. So what is the difference between red cell glaucoma and hemolytic glaucoma? Red cell glaucoma, directly the hemorrhage RBCs go and block the trabecular meshwork. Hemolytic glaucoma, the macrophages which engulf the red blood cells, where those debris will go and deposit in trabecular meshwork. So there is one more entity, that is ghost cell glaucoma, which occurs in aphakic and pseudophakic eye with vitreous hemorrhage. Okay. After about 2 weeks of hemorrhage, the RBCs degenerate. Degeneration of RBCs, they lose their liability and become khaki colored cells. So it is also called as khaki cell glaucoma or ghost cell glaucoma, which passes from the vitreous into anterior chamber and block the pores of trabeculae, leading to raised IOP. So due to hemorrhage, there are three types of glaucoma: red cell glaucoma, hemolytic glaucoma, and ghost cell glaucoma. Okay. So the glaucomas associated with few syndromes are also there. Okay. If you just remember names, that's enough, I think. I don't think so it will be asked for you guys. Progressive iris atrophy, Chandler's syndrome, and Cogan-Rees syndrome. Pathogenesis also not required. This is just the picture of iris atrophy, how it in Chandler's syndrome there will be diffuse corneal edema like this. In Cogan-Rees syndrome, that is iris atrophic patches will be there, pigments on the diffuse pigmented lesions on the iris may be there. So all in all, in the secondary glaucoma, what happens, like the treatment of secondary glaucomas or options for lowering the IOP include the use of topical or systemic medications, okay, medical therapy. If that, along with that, laser trabeculoplasty can be tried, okay, especially in case of pigmentary glaucoma and pseudoexfoliative glaucoma, we can do laser trabeculoplasty. It works better. If these two doesn't work, then we can go ahead and do a surgery. Surgery that includes trabeculectomy or using a drainage devices. Glaucoma drainage devices are also there. Okay, and then if that doesn't work with all this, then final resort will be cyclodestructive procedure. Cyclodestructive procedure is one which is used in the end stage of glaucoma, where there is a painful blind eye. Then we go for cyclodestructive procedure, where we destruct the ciliary processes itself to reduce the aqueous production. So this is about secondary glaucoma. I have finished almost everything in glaucoma. Okay, primary open angle, primary angle closure, secondary glaucoma is over. Okay, I have finished even medical management and surgical management. Okay, maybe in surgical management little bit more in detail, I'll take one more class. Okay. If you have any doubts or anything, I can message. Okay, to this. No. Okay. What else has to be covered in glaucoma? One more glaucoma class will be taken, and then my class will be over. Thank you, students.